welcome to the LifeWorks Living Well podcast. I'm Mark Hennick. This is the last episode of our show, for at least the foreseeable future anyway. Now, these past 3 seasons, they've been at times fun, challenging, emotional, and certainly endlessly educational for me. When the COVID-19 pandemic hit, I, like so many others, was faced with the sudden imperative to either pivot or perish. So I'm grateful to LifeWorks, formerly Morneau Chappelle, for giving me this opportunity to do meaningful work when I needed it the most. Their recent acquisition by TELUS promises to usher in an exciting new era in corporate health and well-being. I hope that you can all go back and check out the episodes that we recorded before and all of our past episodes that we created together, wherever you get your podcast. We're on all of the usual audio and video platforms. Now, I'm going to be back later this fall with an exciting new project, so make sure that you stay tuned to my social pages for when we get that up and running. I'm also pleased to share, for the first time publicly, that I'm going to be making a little bit of a career change, or at least a formalization of something that I've been most passionate about anyway. For my entire professional career, I've worked in some capacity in mental health, but this fall I've accepted an offer to join the Master of Journalism program at Toronto Metropolitan University, formerly Ryerson University. And while I'm admittedly a little bit nervous about going back to university at this stage of my career, at this stage of my life, I'm also incredibly excited to finally take to the next level my passion for the power of stories and storytelling to change things for the better. 3 people in particular have helped in their own individual ways to cultivate this passion in me over the years, and I'm fortunate to have all 3 join me on the show today. We're going to talk a little bit with them about what's happening in health news now. I'm going to get their thoughts on some of the issues that we've covered in our previous episodes, how they've evolved since then, and we're going to look forward a little bit at what's to come. Hopefully we can fit all that in here today, so let's get to it. Avis Favaro is the past longtime medical correspondent for CTV National News, and currently she serves as a journalist in residence at McMaster University. Hello, Avis.
Hi, Mark. Congrats on the new education. You've been a journalist at heart for as long as I've known you, so way to go.
Pretending to be anyway. Thank you. Dr. Brian Goldman is the host of White Coat Black Art on CBC, and his latest book is The Power of Teamwork, How We Can All Work Better Together. I apologize. Brian, thank you for being here.
Pleasure to be with you, Mark, and let me add congratulations to you, too, on your new adventure.
Thank you. Andre Picard is the veteran health columnist for the Globe and Mail, and his latest book is Neglected No More, The Urgent Need to Improve the Lives of Canada's Elders in the Wake of a Pandemic. Andre, welcome.
Hi, Mark, and just joining the others with congratulations and saying all your knowledge of mental health issues will serve you well in journalism, that's for sure.
I hope so. I guess we'll find out. Now, first up, I've got so much that I want to talk to you all about. You've all been such luminaries, such mentors in the background, I think, for me. But I think that really anybody who's been even halfway paying casual attention to health journalism in Canada, this is why I'm so interested in it, they've surely seen the stories about all the impending collapse of our healthcare system, at least. That's what it seems to be on social media. We've got long waits, staff shortages, ER closures. Brian, you've been, beyond talking about these issues in your public life, you're on the front lines of it, of course, as an ER physician. So what are you actually seeing on the ground? Let's start there. Does the reality in healthcare right now match the narrative that we're hearing?
So that's interesting. And the narrative is determined by, I guess you can say it's determined to a large extent by what we're hearing on social media, or it's biased by social media. I objected to the word collapse just because I think it's a visual metaphor that has meaning to most people who use that term. The collapse of a bridge, the collapse of the economic system, the collapse of the Soviet Union. We saw these. Some of these are historical examples. So what does the collapse of a healthcare system look like? Certainly, there are emergency departments that have had to close them. In fact, a couple of weeks ago on a long weekend, 25 emergency departments in the province of Ontario had to close down for several hours, for maybe a day or half a day, part of a long weekend, because there weren't enough nurses to adequately staff those emergency departments. I work in an urban emergency department where there's no question we're seeing fewer nurses on duty. The kinds of things I've seen, instead of having 3 triage nurses, there are 2 triage nurses. Sometimes we've had to press some of our colleagues. In 1 or 2 instances, a physician acted as a triage nurse. More often than not, it's a physician assistant or a nurse practitioner who sits into the role of a triage nurse. So basically what we're doing is we're lending staff to make up for the lack of nurses. And we have had unmonitored areas of our emergency department where we can bring patients in and out as physicians, but if we leave a patient there, they're unmonitored. And that's clearly not a safe situation. And we're seeing that more and more. Is that collapse? Patients are getting seen, getting admitted to hospital. I know there are long waits. So, I'm so far I'm monopolizing the conversation, but from what I've seen, I don't see collapse, but I do see great stress, both among the people who work in healthcare on the front lines and the people who depend on healthcare. I'll leave it to Andre and Avis to give their points of view and whether they think it's a collapse or a crisis.
Well, now, Avis, you've been sharing some stories on your social platforms as well about healthcare privatization, not just in Ontario, but elsewhere in Canada as well. And, Canada has a nominally universal healthcare system, I think, or at least a universal medical care system. So how are people reacting to those stories that you're following?
Well, I'm heartened to see that people are paying attention to the healthcare system, because I know in Ontario, for example, they've tried to make it an election issue with our provincial election during the summer, but it just didn't get any traction. So I believe that at their core, Canadians love the universal healthcare system because it is equitable, because it doesn't matter what money you earn, you will get care for no matter what your condition is. Mental health aside, we can talk about that later. But I think that people are frightened by what they're seeing. So if we go back, and Andre can certainly comment on this, but hallway medicine and the inability to deal with the demand has always been there. I remember doing stories with Lloyd Robertson years ago with people who couldn't get admitted because there were, quote, bed blockers or alternative levels of care, where seniors were stuck in beds because they couldn't go back to their long-term care. So this is a long-standing problem. And I'm seeing people waking up. And they are now hearing signals, certainly from the Ontario government, that there is a crisis that they can turn into an opportunity to privatize. And so that's what I think we're starting to see. Recognition, this is important. Recognition, this is an opportunity to privatize certain things. So that's where the discussion goes. Andre, what do you think?
Yeah, I totally agree with Avis. I don't think, and with Brian, I don't like the word crisis. I think this has been a long, slow degradation. We haven't paid enough attention to it. Maybe things are a little worse at the margins now, and that's what we tend to pay attention to as journalists. We look at the margins. But I always remind people that the vast majority of people get good care, excellent care at the right time. But is that good enough? It has to be everyone. This is healthcare. This isn't Walmart or something. So we have to do better on the edges, I think. The whole issue of privatization, I hope we'll talk about it more. I think it's a very touchy issue to talk about. It's the language we have to be careful with the language. The reality is every healthcare system has some private and public parts to it. And I think what we fail to do in Canada is really draw lines. We have to just be clear what's going to be covered publicly and what isn't. This is my pet topic I've been going on for many years. And I think that's really the heart of a lot of our problems. Every problem we have is structural and administrative in Canada. We have great medicine. We have great hospitals. We have great doctors like Brian. That's not the problem. We have to make it easier for them to care. We have to make it easier for people to get care. And we have to be clear what they can expect. Like, what is our expectation? We want the world. We want everything, and we want it to be free. And we've been sold a bill of goods for many years. We're not going to get that. So we have to draw these lines and be really clear what's covered. We have to be clear on what universality means. Universality doesn't mean everything is covered for everyone all the time. It means we provide the basics to everyone in an affordable fashion. Those are very different things. There's a lot of big topics that I hope we'll get into, and maybe this crisis talk will force us to talk about that. But I'm not entirely convinced, because as Avis said, this is very cyclical. We've talked about this over and over the decades. We've all been at this for decades.
Well, and
Mark,
Andre, I can't help it. Please go ahead. Yeah.
Yeah, I was just going to say, if there is one thing that is different, people on the front lines are more fed up, more burnt out, more angry, more vocal than I'm used to seeing. And I haven't heard people talk about wanting to throw in the towel, saying they're fed up, not afraid to speak up about what their institutions are doing or not doing or failing to do. And complaining about politicians. That's something that's different. And I think that has a lot to do with where we are in the pandemic. And, for instance, I can tell you, having been called in to work shifts because colleagues are sick or on COVID self-isolation, that I've reached my limit. And I think a lot of my colleagues have reached their limit. That's one thing that's different. That's particularly true for nurses.
I can't help but feel like this was part of the game all along. I don't know if that's the cynic in me or the, from a political perspective, to let the status quo collapse so that way it sways public attention, public opinion, and then it seems like there's some pretty powerful.
Wonder.
It does. Yeah, there's some pretty powerful corporate interests at play here. So what's the answer then? I mean, this has been Avis, go. This has been studied to death, and it seems like our system works better than a private system, even though it's collapsing or crisis or whatever the language is. So Avis, I mean, what's going to happen here? What do you think?
Well, I don't know, but I know that some journalists are actually, I'm not focusing here on Ontario, but, there are a list of private companies that are lobbying the government to provide services. And some people, like my husband, think, as long as you get the services, it doesn't matter. We'll figure that out. But, it does seem, I kind of wonder at the lack of urgency when a politician is invited by a frontline doctor to come in and see what's going on, rather than just speaking from Queen's Park or, a government office, to actually see what's going on. And they don't take them up on it. I kind of wonder about what signal that sends. The thinking and the planning is done at one level. And then, as Brian's saying, people are burned out. And I don't know what we're going to do in the fall when things will heat up again, because we're going to have flu and, what other respiratory viruses are going to be going around. So that's my concern. I am puzzled by the lack of response from government officials.
Now, Brian, you mentioned that a key part of the crisis, or what's happening right now in healthcare, is that people are just burnt out. I mean, we talked about this, you and I, in a past episode of this show as well, when it was starting to take shape. I mean, healthcare employee burnout is not a new thing, but it certainly has ramped up. And it seems like now workers are just like you, just fed up, and they're avoiding and they're leaving the healthcare workforce, not being replaced in time to really maintain the capacity. So I'm wondering what are governments and healthcare administrators not getting about what people in the healthcare workforce actually need to stay in the job, to recruit more people into the job?
Well, are they getting it? Are they not getting it? Or is this playing into what they want to get? The conclusion that they want to reach, what Avis has just been talking about. I think it would not surprise me if you listen to what's going on in British Columbia with TELUS. They're moving heavily into private healthcare, and so it's not surprising as these little windows, these little pilot programs start in different parts of the country, that they're creating some facts on the ground and creating an argument for private. But to answer your question directly, what are they not getting? There's two things that they're not getting. The first is the Great Retirement. There's no question that family doctors, for instance, if you look in British Columbia, 40% of family doctors, current family doctors in practice, will retire within the next 10 years. That's a staggering number for a province that already is about 800,000 people don't have a family doctor, don't have access to primary care. So the Great Retirement is one thing, but then add to that just how fed up people are right now. We're in a situation where we have to provide, for instance, in the emergency department, we have to provide 24/7 care. And if somebody in our group, and at our hospital, we have 7 shifts a day. That's 7 human beings who have to be there. You can't double up. You can't double shift yourself. We have an on-call person. And if any one of those 7 either test positive for COVID or is a household contact of somebody with COVID. And I had it, I had that about 2 months ago. Then you contact the group and you say, I'm out. And you're either out for 10 days or you're out, if you're fortunate, for 5 days on the accelerated plan. But during that time, if you're in the thick of your own schedule, if you're working for 5 days in a row, that means that's 5 shifts that have to be covered by the on-call person. We're on the on-call roster for a reason, and now we have a second person on call as well. But there's a point at which there is not an expectation that every time you're on call you're going to be called in, and that is happening more and more. And there is a martyr complex in healthcare, amongst healthcare people, where they just say yes to everything, yes to every committee, yes to every shift, yes to every extra duty. Oh, I can do that. I can do that. I can do that night shift if somebody will take my evening shift. But there's all that means is that you're pushing the breaking point to this small window where once it happens, they're gone. They're not saying I'm sick and I need help, or I need to take a little time off. They're saying I'm gone. And that's the martyr complex that we often see in healthcare. So those are 2 of the things that they're just not getting. The other thing they're not getting in Ontario is how easy it is to piss off nurses. And Bill 124 waved a red flag in their faces. They know. All they have to do is the argument for it now. They can say, you know what, we didn't anticipate that inflation would be so high. It's cruel and unconscionable to restrict a wage increase to 1% just because we said so at a time when people are paying 8, 9, 10% more for basic necessities. But they're not doing that. So clearly there's a whole bunch of things that they don't get. And it's either because they can't see it or because they're in a bubble or because they don't want to get it.
Well, and particularly, we in healthcare, but we're seeing this in education and other sectors as well with inflation and labor actions starting to pile up. I think that's only going to continue. But Andre, I want to come back to you here. Given the realities that Brian has been talking about here, the pandemic has delayed or canceled huge numbers of elective procedures. It's disrupted routine and preventative healthcare. So do you think that that's the system trying to catch up to pent-up demand? And if so, is the Canadian public sort of sympathetic to that? Do they have patience to deal with this backlog that we're still trying to recover from?
Well, I think the short answer is, do they have patience, is no. I think the backlog is an issue. There's no question the pandemic has had a real impact. But we have to remember this was a problem before. We have these backlogs every summer. We've always been understaffed. The system is poorly administered. You asked Brian what's the fundamental problem? And I think the fundamental problem can be described in this line, the sociologist Pat Armstrong, who said, the conditions of work are the conditions of care. We treat our workers badly, they're burning out, and invariably the care is going to get worse. There's a direct connection there. You can't magically have good care if you take poor care of your workers. I think we really have to put the emphasis on the workforce. The frustration for me, someone who's been doing this for a long time, is this was all entirely predictable. It was accelerated a bit by COVID. I wrote a book in 1996 about the coming nursing shortage and how there was going to be a crisis. I'm not some brilliant guy. This was really obvious, and it's been obvious for a long time, and we've sat on our hands. We've done nothing about it, and we're reaping what we sowed. Our indifference is coming to the fore right now, and we're seeing it mostly with nurses because they are really the backbone of the system. They hold things together 24/7, and with the nurses leaving, we're in big trouble. This can't be fixed easily. We're not going to just be able to import thousands of nurses from the Philippines because every other country is doing the same. We're not going to be able to train people because that takes years. The real frustration to me is we have tens of thousands of qualified nurses who aren't anymore. We have better retention. We have to have more flexible workplaces, so we don't have this union dogma about everybody has to work full-time when half the people don't want to work full-time. They want to work part-time. There's a lot of solutions out there, and we're just not implementing them. And that to me is what's unconscionable about this. Is it shouldn't be happening.
Certainly shouldn't be. We have to take a quick break, but when we come back, I'm going to talk with Avis, Brian, and Andre about the state of long-term care, as well as about the evolution of medical assistance in dying. I'm also going to get their forecasts on the coming trends in health news to come this fall. I'm Mark Hennick. This is Living Well, and we'll be right back.
We are always moving forward. In our changing world, there is an unchanging principle for success that inspires us. By improving a person's life, we'll improve how they perform at work. We are LifeWorks. We're the world's leading total well-being provider. We are innovators with tech-enabled solutions and one integrated platform. We have the scale of a large company with the agility of a startup. We are experts in our sector and are continually learning so that we continue to be valued and trusted partners. Our mission is to improve people's lives by supporting the whole person, their mental, financial, physical, and social well-being. We empower people to prioritize their well-being and help them with challenges at important moments in their lives. We believe this creates happy, healthy, and empowered people. These people are the heart of successful organizations, leading these organizations to a more resilient future and making a real difference in the world and in our communities. We are moving forward with purpose. Improving lives, improving business. We are LifeWorks.
Welcome back to the LifeWorks Living Well podcast. I'm Mark Hennick. I'm here with Avis Favaro, Dr. Brian Goldman, and Andre Picard, the Avengers of health journalism in Canada. I don't think it's an overestimate to say that. So I'm going to get off on a little bit of a rant here, if you'll indulge me, as we move into our next topic. This country, in my opinion, is on the verge of having among the most permissive medical assistance in dying regimes in the world. On just the last episode of this show, I spoke with a psychiatrist, Dr. Sonu Gained, and he chairs his hospital's MAID committee. So he's not a conscientious objector to the procedure at all, as he says. Yet he still vocally opposes assisted suicide when it's administered solely for a mental illness, where the person is not otherwise dying. As a subject matter expert on mental illness, he has many reasons for his objections, including that we can't reliably predict irremediability when it comes to mental health problems. That is, there's no evidence to support telling somebody with a mental illness that they won't get better. And one reason among many that I agree with him on that is that mental illnesses aren't just exclusively medical matters, at least not to the same degree that other MAID-eligible illnesses are. They're highly influenced, or often causatively by social determinants like income, housing, and the social exclusion of stigma. So with all that said, Avis, you and your colleagues at CTV have, among others, have been reporting on some of these stories of the largely, or at least partially, non-medical reasons that some people have been seeking a physician's assistance to end their life. So what have you been learning from getting to know these people, reporting on their stories? What have you been learning about the motivation behind why some people without a terminal illness seek MAID?
Well, so I've been watching medically assisted dying for years. I believe I'm the only journalist to actually have interviewed Kay Carter of the Carter decision before she went to Switzerland to have her death. But, you know, her life and her death have changed the landscape in Canada. And I started to hear, I think most Canadians accept that medically assisted death for a terminal illness and, you know, the death is foreseeable is fairly straightforward. But then the law started to change to allow for track 2 cases where death is not foreseeable, chronic pain, and things like that. And then I started to hear stories like that of a gentleman with a hearing problem and some mental health issues who suddenly got approved for MAID without his family knowing. And that set up a case. And we have people who are disabled, who need better housing, who have been offered MAID. In one case, they got MAID. So I think you're starting to see questions come up. And Europe has gone through the same situation where they've had laws in place or regulations, and then they start seeing where the cracks are in the system. And right now we're with CTV, we're looking at made for mental illness. And there are a lot of questions emerging. Before we go on, I want to say that the latest data shows that in 2021, the number of MAID cases in Canada went up to about 3.3%. That's over 10,000 people in 2021. It's an increase of 30-something% over the year before. And when you break down the numbers, all the provinces have had increases in medically assisted death for track 1, foreseeable death, and 2, those who are not terminally ill. And only 4% of those who apply are getting rejected because they're not deemed eligible for it. So very interesting trend. We're going to keep looking at that.
Andre, I want to bring you back in here because we talked about this not when you were on this show, I think way back when you were on my other show. And I think we disagreed a little bit, and that's okay because reasonable, intelligent people can disagree. So since that was a couple of years ago now, I'm interested in hearing if your position on this or your view on this has evolved at all. My view was that people were oversimplifying mental health to say, depression is just like cancer, which of course we know that's a nice metaphor, but it's not actually medically true in my view. So I'm wondering if your position on this has evolved at all, especially being in Quebec where so much of this has been generating from.
I think, there's no question that the laws evolve, so our thinking has to evolve a bit. This is messy at the edges. I think, to me, I'm probably the more libertarian person on the panel. I believe people should have the right to ask for MAID in all kinds of circumstances. Suffering is suffering. It makes me uncomfortable when I hear these stories about, somebody's requesting MAID because they can't get housing. That's not right. I'm not sure it's happening. I'm not sure they're getting MAID. But the issue to me is, yes, we have to do better care of people with disabilities. We have to provide better housing for people who need it. But the answer isn't to deny MAID to people who are suffering. I think we have to make that distinction. I think a lot of anti-choice people are exploiting people with disabilities, etc. It reminds me of the abortion fight, which I've covered since the 80s, very similar parallels. So I think we have to make sure that people have the right to end their suffering, but we absolutely have to have ballasts. We have to make sure that this is appropriate. It's not done, willy-nilly, and I don't think it is. I think there have been cases that are questionable, but we have to be careful about this. But it's always going to be messy. This is difficult stuff.
My concern here is that mostly I always come back to the decision pathway, the cognitive pathway, the choice architecture between behind why somebody got to that decision in the first place. If they have end-stage cancer, that's very different from if they've suffered in a mental health care system that doesn't work, that might have actually made them worse. Now, Brian, I want to ask you about this as a physician. Somebody comes to you and they ask for MAID or they ask for anything else that maybe, I don't even know how that interfaces yet with your Hippocratic oath to do no harm if the person is not already dying. How do you handle those kind of ethical dilemmas as a physician?
Well, I think that, if you're going to invoke the do no harm argument, that cuts both ways. If somebody is suffering, then denying them an opportunity for an assisted death under the circumstances that over which they have some control and a greater degree of comfort. And they can have it in their home surroundings if they want to have it. I think denying people that is a form of harm. So personally, I'm comfortable with the idea of an assisted death being a way of providing comfort to somebody who cannot be comforted because of their illness, either physical or in some cases emotional. I will say that if I am concerned about one thing, it's the notion that an assisted death is available and it's available in lieu of proper care, either mental health care or even medical care. And I don't know about you, Avis, but I'm certainly hearing, or Andre, but I'm certainly hearing about cases of people in certain parts of the country where they have a medical illness, or at least a suspicion of a medical illness, a brain tumor that's probably inoperable, or cancer of the pancreas, for instance. And in a window of time when it's taking too long for them to see an oncologist to get an opinion on what kind of treatment, maybe it's not curative, but maybe it's palliative, and maybe it can extend their life and improve their quality of life for a period of time, but they don't get an appointment with that oncologist for 8 or 9 or 10 weeks, but they can get MAID, in a much shorter period of time. And so they're opting for MAID in lieu of getting that opinion from an oncologist. That makes me uncomfortable. Or somebody who doesn't get an MRI of their brain to further discern the nature and the extent of an inoperable brain cancer that they have, a glioblastoma, might be a glioblastoma multiforme, and they are going to die. Their prognosis is not good, but they don't get an appointment for an MRI for 10 weeks. And in the interim, they're able to have MAID. These are true stories. These have actually happened, and they make me feel uncomfortable. I don't want to have a system where people are opting for MAID because the system isn't providing the medical care that they need or the diagnosis that they need in a reasonable period of time. And I don't know, Avis, if you've heard of cases like this or what you think of that.
Yeah, absolutely. Especially with mental health care. I've spoken to a young man who actually was prescribed 2 forms of therapy, ketamine and transcranial magnetic, for his severe depression. He's suicidal, and he was deemed not eligible because his depression was too severe. And so here he is discussing with me about getting medically assisted death because his province won't give him therapy. He wants to get better. He wants to try to get better. I'm also hearing in some cases where MAID practitioners are actually approving MAID without consulting with the patient's actual family doctor about what's going on to get a real assessment. They're doing assessments by Zoom, and they're getting approvals to have this done. So there's some gray areas, and I've been watching what's happening in Europe, and they've actually closed the barn doors a bit because some cases were just getting out of hand with people with autism being approved or prolonged grief when we really don't know. There's just research starting to come out now. So yeah, I wonder, internationally, what the world will think of Canada if we offer MAID without offering services first, be they medical or mental health care.
And then I think at its core, we talked about this last week as well, Andre, you mentioned the libertarianism piece. I think at its core, that's really what this is. Do people have a right to die for any reason anyway? And, suicide's not a crime in Canada. It was removed from the criminal code, which is the right thing to do. It's an illness. It's a part of an illness very often. But I think at its core, it really comes down to this idea of whether or not people can make the decision for any reason, whether or not they want to be alive or dead. And I think, Andre, actually, sorry, go ahead.
Yeah, I was going to say, I'm a great believer in choice, but I agree with the other two. I believe that no one should be getting MAID because they're not accessing care that should be available. Nobody should be getting MAID because they can't get housing. But the issue there is not MAID. The issue there is bad health care and bad social programs. And that's what we should be talking about. Nobody should be homeless in this country, whether or not they're going to invoke MAID. That should have nothing to do with it. That's where we should really focus on. And that's what bothers me about some of these cases, how they're being exploited I think, for ulterior motives.
I think we all agree on that. Yeah, Brian.
One thing I'd want to know, Mark, is, and ask everybody on the panel, should we have a system where the request for MAID automatically floats somebody higher up on the priority list to receive services? Is that something that we should do, or is that or will that result in gaming the system by saying that if you don't give me what I want, I'm going to request MAID, and effectively blackmailing the system to provide better care? I don't know the answer to that question.
Well, we've actually already seen that in terms of parents sometimes tell their kids, we've heard this for years, if you want to get mental health care, you have to get arrested. You have to be brought in the back of a police car. Sorry, Avis, go ahead.
No problem. So yes, you're absolutely right. I have friends where they had to get they had to call the police in order to get their kids care. But the thing is that in Europe, you actually see more safeguards before someone gets approved for MAID. I think the rejection rate is something like 50-60%, because they have to show that therapies have been tried and that, treatments have been offered. It's a different country, smaller countries like Belgium and the Netherlands. But in Canada, the way we're going is very liberal. You don't necessarily have to accept in mental health any treatments. So there's no onus on the people who approve MAID to say, have you tried better pain management? Have you tried this? Or speak to the person's physician to see what has been tried, or are they in the middle of treatment, so they get a fulsome picture. So in Canada, people around the world are telling us that we are going to be the most liberal in the world when it comes to medically assisted death. So, you have to listen to that because we are providing MAID before we're looking at, can we provide the services that might prevent people from asking for this?
I think especially when we see the demographics changing, Andre, you and I have talked about this a couple of times too, the so-called gray wave or whatever it might be as boomers start to age and enter into the time in their life when they need the most healthcare. I can't help but think about MAID, and I want to move on from this topic, but it's in the economic interest of the country as well to end people's lives before they get too sick, before they get into the stage where they're using so many services, because that's expensive to do. So that reminds me, Andre, when I think of end of life stuff, whether it's reasonably foreseeable or not, I can't help but think about the elderly in particular, even though the elderly aren't necessarily the biggest demographic that are receiving MAID. But we had you on a while back and talked about the really tragic situation, of course, in long-term care facilities in Canada. You wrote a whole book about it. So how's the situation improved, or has the crisis deepened along with the rest of the healthcare system?
No, the situation hasn't improved dramatically. What we saw during COVID was, like everything else, it was an exacerbation of a problem that already existed. It was the perfect storm. And we saw, I call it in my book, a massacre of neglect, right? So we've had 43,000 COVID deaths in Canada. 22,000 of those have been in long-term care homes, more than half. This is just, again, it's unconscionable that, and it was also very predictable. A lot of people in these homes were sitting ducks. The facilities were outdated, 3-4 to a room. It was just a perfect circumstance for the spread of illness, understaffing, poorly trained staff, underpaid, very sick people. Everything was there. But again, I remind people, this was happening in slow motion before COVID. Way too many flu deaths, food poisoning deaths. A lot of people die in homes. They're all going to die. They're old. They have multiple conditions, but they're dying unnecessarily quickly. No palliative care. One of the great tragedies that I learned about during COVID is that only about 6% of people in long-term care homes get palliative care. 100% of them are going to die. Why are 94% not getting comfort at end of life? So there's all these really, again, it's all about systemic issues, about taking care. Do we value our elders? I think is the question my book asks. And the answer is no, we don't. We treat them with disdain. We send them off to these homes, sit by the side of highways, out of sight, out of mind. And I think that's what has to change, is our attitude about, we want people to live the best life possible as long as possible. They're not going to magically live forever, magically live in good health, but we can give them better, more dignity and more quality of life.
Brian, as bad as it is for staff working in a hospital kind of setting, what are your thoughts on the staff that are working in long-term care homes, which sometimes I think are almost as tragically forgotten about as the residents there, or the staff who live in these places? What are your thoughts on those?
Well, they're doing the best that they can under trying circumstances. There isn't a lot of input from physicians. It's mostly nurses. Often the chief of the clinical staff is a registered practical nurse. A lot of the care is provided by PSWs, and we know those PSWs are as traumatized as the people who work in acute care settings like emergency departments and ICUs. And there aren't enough of them. And frankly, they're not paid as well as they should be for the care that they provide. I know from personal experience of loved ones, I've had about 4 or 5 loved ones in long-term care over the last 8 or 9 years. The care you receive it has less to do with the facility and more to do with the quality of care that's provided by those frontline workers. They are, the best of them are saints. The worst of them shouldn't be in the business. I'd like to think that more of them are saints. I certainly share Andre's concern for the disdain with which we hold people who require long-term care. There aren't enough adequate long-term care facilities. There aren't enough well-trained and caregivers. And certainly from what I've seen recently, if you think that home care is the antidote for long-term care, well, you've got to put funding into it. And, it's inadequate. It's worse than inadequate. I think more often than not, I'm hearing stories of people who are eligible to receive 20 hours a week and are getting no hours a week because the system can't provide it for them. And I think it's pointless to say, you're eligible for 20 hours if the system can't provide you a single hour of care. And that's the kind of situation that we're dealing with right now. So it's a drastically underfunded system that frankly, we get what we pay for in terms of taxes, and that's the thing that makes me despair more and more.
What you said about home care reminds me of the deinstitutionalization of people with mental illnesses. Let's go and get them care in the community, which is a great model. Oh, but by the way, you actually have to fund care in the community. You can't just close all the hospitals, because then, as we've seen, people end up in prison and on the streets instead. Now, Brian, we've only got a few minutes left here, but you've got your finger on the pulse, both literally and figuratively, of healthcare in Canada. So what do you think are the emerging issues or the moving health stories that are going to blow up this fall coming? What's on the horizon?
Well, I think that, we might, certainly I think it's fair. We're going to, on White Coat Black Art, we're going to examine the issue of collapse. Are we actually moving more towards something that people would all agree of is collapse, is something that's more in keeping with the word collapse as opposed to a crisis or a slow moving crisis, whatever you want to say. In primary care, home care, long-term care, acute care, we're certainly seeing evidence of it in different pockets. But I want to look at solutions as well. I mean, I wrote a book called The Power of Teamwork because I believe that there aren't enough healthcare professionals that we can poach from other countries if we wanted to, and I think it's unethical to do that. I think we're going to have a model where we have people who are paid less money who are supervised by those frontline workers in a team model. And I think it can work. It's something that I want to see explored. That's something I'm going to be watching. Of course, I'm also going to be watching the emergence of new infections like MPX virus. I'm going to be looking at things like how bad a flu season we're going to be having this year, and I hope it's not as bad as it was in Australia, although I have my fears.
Avis, what do you think we're going to see coming around the bend in terms of health news this fall?
Well, number one, I'm concerned about the state of our healthcare system, because if they're exhausted now, summer is usually when you rest your horses in the hospital system, and they're renewed and fresh for the fall. So I really don't know about that. It's hard for me to predict. The flu in Australia, as Brian mentioned, was a tough year. It's quite possible, and I know the CDC is also looking at the possibility there could be a rough flu season. So that will put further pressure on the healthcare system. I would love to see some solutions. I'm frustrated by the fact that we do show problems with long-term care. The private nursing homes did better in COVID than do for-profit, but yet we're funding more for-profit in the same sort of silos of, care where people will get sick because they're all housed together. So I really don't know. I'm a little bit nervous about the fall because I think we just don't get it. We don't get the one world concept where viruses in China become issues for us here. Monkeypox in Africa can simmer for 3 years and become issues here. We're still not getting it. And there's too much on everyone. People are exhausted. So I'm kind of holding my breath.
Andre, last word to you. Take a peer into your crystal ball and tell me what's the next big health story that you're watching.
Well, I'd have to echo the two other big brains on the panel. Definitely the flu, the confluence of flu and COVID, monkeypox. The fact that we now talk about pandemic in plural is disturbing to anyone who knows anything about global health. So I think those issues are all really important. But I think it's all about the system. To me, as journalists, the challenge we have now is, we're doing these really good reporting on all the things breaking down. Our challenge is to start proposing solutions so that people just don't lose hope and give up and say, oh yeah, what the hell, let's just privatize. That's the worst thing that could happen. We have to give people hope. We have to remind them that the care is really superb. When you're in the right place at the right time in Canada, care is second to none. But we have to make that journey easier. We have to make the structure better. And we have to have the tough discussions about, well, what are we going to cover in our public system? And then we got to really pound some money into it and ramp it up and do the core stuff really, really well. And we're not doing that.
Keep up the hope. Well, this has been everything that I hoped it would be. Unfortunately, we don't have any more time, so we have to get going. But thank you all three of you, so much for doing this. It's been a real honor for me to be able to hear your insights.
Thank you, Mark.
Avis Favaro was the longest-serving national medical correspondent in history for CTV News. Dr. Brian Goldman is the host of White Coat Black Card on CBC. His book is The Power of Teamwork, How We Can All Work Better Together. And Andre Picard is a longtime health columnist for the Globe and Mail, and his latest book is Neglected No More, The Urgent Need to Improve the Lives of Canada's Elders in the Wake of a Pandemic. Thanks to you all again. Have a great day. Well, that's it for me, and that's it on Living Well. Many thanks to our guests today, Avis, Brian, and Andre, and to all of my guests for the past 3 seasons. And thanks to you, as always, for listening and for watching. You can still subscribe to the show wherever you're getting it: YouTube, Apple Podcasts, Google Podcasts, Amazon Music, Audible, Spotify, iHeartRadio, and everywhere else. You can also go back and check out all of the episodes from our 3 seasons so far on any of those platforms, as well as at livingwellpod.com. You can connect with me directly on Twitter, Facebook, Instagram, LinkedIn, and YouTube at Mark Hennick, and I hope that you do, so that you can learn more about what I'm going to be up to next, and to share your stories with me, hopefully, as well. I stream all of the video from these episodes on my social platforms, so let me know what you thought about the show in the comment section there. If you found them helpful and inspiring, please share the episode with your friends and with your networks. Thank you again so much for sharing some of your time with me. I've been your grateful host, Mark Hennick. Until next time, take care and live well.